Hi, this is Junaid. I'm going to present stroke and atrial fibrillation today. No specific disclosures for this particular presentation. Objectives of this presentation is epidemiology of AFib, stroke risk in AFib, stroke severity in AFib, and role of anticoagulation in AFib. So atrial fibrillation is basically irregular rhythm, and there is no repetition patterns of the RR intervals. So moving to epidemiology, incidence increases with age for all races. This is directly from Heart and Disease Stroke Statistics 2019 update. As you can see, no matter what your age range is, with increasing age, atrial fibrillation incidence increases. So as a matter of fact, it's been theorized that if everyone lived above the age of 110, everyone will have atrial fibrillation. This is from 2004 Circulation Journal, which was made into an infographic. Basically tells like there are 5.1 million AFib people living in the US and 4.5 million in Europe. That is back in 2004. And the prevalence is supposed to be doubled by 2050. 1 in 4 above the age of 40 will have AFib, and about 2% of the general population worldwide will have atrial fibrillation. So this is going to be a global epidemic of this disease. So this is not something small, and we should all know about this. So current and future prevalence of AFib in US, again from the same 2019 statistics. As you can see, back in 1995 there was 2.3 million, 2010 5.1 million, and by 2030 we're looking at 12.1 million AFib survivors or patients with atrial fibrillation. One of the biggest risk factor is hypertension, then of course obesity, smoking, diabetes, and cardiac disease as one of the leading risk factors for atrial fibrillation. We'll come back to it again to see why it is important. As you can also notice, all these are also risk factors for stroke. It is not a cheap problem. In 2005, we spent about $26 billion on AFib, which was significantly higher from 2001. So there are significant costs attached to it. The biggest cost is indirect inpatient cost, rather than medication costs, etc. So there's a higher propensity of patients to be admitted with atrial fibrillation. This is another cost analysis that was done by Heart Organization, and you can see AFib costs $26 billion every year to healthcare. Each hospitalization costs an extra $8,000. So, and then the worst part is that they get readmissions more so, and then CME basically penalizes you for readmission. So this is a big problem for the healthcare. Stroke risk and atrial fibrillation. So atrial fibrillation has associated 4 to 5-fold increased risk of ischemic stroke. As you can see, AFib increased the risk of stroke by 480%, which is about 5-fold as compared to heart failure, coronary artery disease, or high blood pressure. One thing that I do want to point out that atrial flutter, on the other hand, does not have this high of increased risk of stroke. The longer you have AFib, the higher chance you will have stroke. So clearly, as you can see, cumulative incidence on the y-axis, and on the x-axis you can see the number of years, and you can see the chances of heart failure, myocardial infarction, stroke, and death. All of them basically increase. As the longer you have AFib, the higher the chance you're going to have a stroke. How do we normally calculate risk of stroke? Traditionally, we use the CHAS-WES2 score on the left, table 1, and then currently we are using CHAS-WES2 score, which is on your right. As you can see, we initially used on the CHAS-2 score when the patient reached the total point of 4, 2 or more, you could start basically anticoagulation. And then as you can see, when we move to Charles-West 2 score, it also started oral anticoagulation above 2. As you can clearly see, that for chances of Charles-West 2 score, for us, at least neurologists, because we're probably going to see a patient that the patient already has stroke, for us, starting anticoagulation is a no-brainer, because they wouldn't show up in my clinic or inpatient. So technically speaking, whenever an atrial fibrillation patient is seen by me, anticoagulation needs to, so makes sense. If you look at the risk-adjusted score, which is very important over here, Charles-West 2 actually has an adjusted score of 2, and you can see over here, however, has a 4% per year risk of stroke, as compared to Charles-West 2 score of 2 only has a 2.2% per year. This is extremely significant, because what it does teach us is basically that Charles-West 2 score is technically much tighter score, and people are started on oral anticoagulation sooner. So which one should you use then? I mean, that's a clear question. I mean, I just compared the two in front of you, but if you can look at it, this particular paper, they compared 9 risk schemes, and there was no profound difference in risk stratification accuracy. However, Charles-West 2 score performed the best. So use that. People forget that even if you do not have a clinical stroke, the chances of having a silent ischemic stroke in patients with atrial fibrillation is significantly high, and none of the scores actually can take that into account. So when you are thinking about a patient with atrial fibrillation, and for somehow it showed up in your clinic for, let's say, peripheral neuropathy and is not an anticoagulation, you should ask the question why. Because even if they don't have a clinical stroke, they are at a significantly higher risk of developing a stroke. As a matter of fact, the odds are 5.5, as you can see, and patients with AFib have 28.3% risk, while with no AFib have 6.6% risk. So clearly, silent ischemic strokes happen in patients with AFib. Now let's turn to stroke severity. This is a fantastic paper that was published in Stroke Severity and Atrial Fibrillation. At the very bottom you can see so risk of fatal strokes with atrial fibrillation is double as compared to patients with non-atrial fibrillation. So it's not just that they're at risk of stroke, it's also that the risk of severe stroke and fatal stroke is higher in patients with atrial fibrillation. As you can see, survival with AFib the probability of survival is low, and more importantly, the probability of recurrence is high. So I mean, these are all no-brainers at this point in time, but at least the data confirms everything that we hear. So the predictive factor for severe stroke and early death in acute ischemic stroke is significant. This is actually a study from Japan, another study that confirms it. This is another study from Australia, again saying the same thing. Increased rate of poor prognosis, death, and in hospital and neurological complications if the patient has AFib. This is another important thing, that not only the oral anticoagulation decreases the frequency of stroke, but also decreases the severity and the death from stroke as well. A fantastic study that was done back in 2003. So again, it is not just oral anticoagulation is not just to decrease the frequency of stroke, it also decreases the severity of stroke, it also decreases death from stroke. So role of anticoagulation, what are we really worried about? We're worried about bleed and fall. So let's calculate both the risk of using anticoagulation in atrial fibrillation. So the calculation method to be used should be Hasbled, and there has been 3 different scales: hemorrhages, atria, and Hasbled. According to this clinical study, Hasbled demonstrates a significant predictive performance for intracerebral hemorrhages. That's what we are the most worried about. However, use whatever you like. One more point, though, that these have modest performance in predicting any clinical relevant bleeding. So even if you're using it, use it with a grain of salt. This is the Hasbled. It actually, interesting, uses most of the stuff from the CHA2DS2, hypertension. So either way, you calculate the number of points the patient has, and according to the risk score, you can basically predict that how many bleeds will happen per 100 patient years. And literally above 2, and as you go above 3, 4, and 5, as you can see, the risk doubles every single point, and it becomes significant. So anything at 2, I'm okay with. Anything above Hasbled of 3, 4, and 5, I'm going to have a discussion with the patient and may still start an anticoagulation, but at least have a discussion. Even with a significant risk of bleeding with anticoagulation, the net clinical benefit of warfarin is significant. In almost all patients with atrial fibrillation, the risk of ischemic stroke without anticoagulant treatment is higher than the risk of intracranial bleeding with anticoagulant treatment. This is studied in 2012, and this was 180,000 or so patients, and basically looked at all the numbers and calculated that anticoagulation, period, is better than no anticoagulation. This is how they were actually able to calculate some of these scores, and you can see that at what CHA2DS2 score as compared to Hasbled score has the highest potential. And interestingly, a very low CHA2DS2 score, which is 0 and 1, clearly you shouldn't start anticoagulation at that point in time anyways, and anything above 2 clearly shows that the benefit is more than the risk. And of course, the other very extreme is where your Hasbled is severely high, 8 and 9, and again, at that point in time, your CHA2DS2 is severely high too, and at that point in time, the benefit mutes as compared to the risk. So please calculate CHA2DS2 scores and Hasbled scores for your patient. Your gut is fantastic, but let's data guide you. Now, the second biggest issue is fall, and people have been talking about if fall should be an important factor in deciding resuming or starting an anticoagulation. And this was a study done in 1999, Archives of Internal Medicine, and it basically said that patients' propensity to fall should not be a factor in decision to start anticoagulation. As a matter of fact, it calculates if elderly person falls, an elderly patient falls about 1.8 per year. The risk of subdural hematoma should be 535-fold. Let me rephrase that. So persons taking warfarin should fall about 295 times per year for warfarin not to be the optimal therapy. So the risk of having a ischemic stroke and the risk of starting a warfarin is so important that if the patient is actually falling literally every day, then you can say, okay, the risk of fall should be taken into consideration. There's one exception that I still do tell people, or at least my students, is patients who fall backwards. For example, our patients with Parkinson's disease, and they can have a posterior fossa bleed, and that could basically be directly life-threatening. So for those patients, you can have a chat with the family. I still believe that I have personally offered them anticoagulation and will continue to do so, but at least they should know the risk of getting into what they're getting into. Again, the risk of stroke is so high, the severity is so high, the risk of dying from the stroke is higher, that no amount of falls, in my opinion. I mean, unless the patient is falling every day, which, to be honest with you, at that point in time, the patient should be wheelchair bound or bed bound, so it doesn't matter. Again, this study has limitations, but it does give you an insight that fall is a factor, but not the most important factor in deciding anticoagulation treatment. So again, just to summarize, prevalence of AFib, it is significant and will continue to rise. Stroke risk in AFib, use CHADS-VASc2. Stroke severity in AFib, not only it increases the risk, but increases the severity of stroke and increases the mortality due to stroke. Use of anticoagulation is the key, and especially in the areas of NOACs, which we will discuss in the next lecture, that how important it is. One more topic that I did not include was that Afib pathophysiology is basically so ingrained in the stroke pathophysiology. So if you look at the risk factors of AFib, it's hypertension, diabetes, obesity, obstructive sleep apnea, alcoholism, CHF. If you look at all of them, these are basically what we think that is actually all the risk factors for stroke. So is it really that stroke is caused by AFib, or is AFib a marker of further bad disease? So people believe that this is basically a vicious circle, and then all these bad risk factors that contribute to both atrial fibrillation and stroke are intertwined, and therefore you would see that left atrial volume is slightly higher in most stroke patients even without atrial fibrillation. So there are different types of AFib, and then does that AFib burden actually matters? AFib burden by definition doesn't matter. So a person who is in long-standing persistent AFib actually has a lower chance of having a stroke with patients with paroxysmal AFib. Again, we don't really have strong data. I have, of course, this one study at the bottom from Japan that I have actually shown you, but at the end of the day, paroxysmalness, intermittent going into AFib and out of it, is considered the highest risk factor for developing stroke. So there is a complex relationship between AFib and stroke, and the idea is that both of them represents diseases coming from the same risk factors, and AFib is also a risk factor, but also it is a marker for further risk of stroke. So the next lecture we'll be doing is stroke and NOACs. Again, thank you, and as usual, subscribe and visit my website.